and other things, so it Right, welcome to this Health and Wellbeing Board on Thursday, 10th of November, and we have a few items to go through, very interesting reports to be received. And the first one, any apologies for absence?
Yes, Chair, there's apologies from Jackie Daniel, Liz Morgan, Guy Renner-Thompson and Christine Wardlaw.
Thank you. Thank you, Wesley. Shall we approve the minutes of the last meeting as a true record? Any observations, comments? Thank you very much. Disclosures of interest. If there is any disclosure of interest, can you please spell it out? There is none, apparently. Okay, we come to the first real item, meaty item. That will be a presentation from our Deputy Fire Chief Officer, Graham Binning. All the best.
Thank you.
It's yours.
Thank you. Good morning, everyone. I'm delighted to be recently co-opted to be a full member of the Health and Wellbeing Board, and doubly so to be able to, in such quick time, have the chance to sit in front of you and talk to the wider fire and rescue service offering that we're shaping up. So as the Chair said, my name's Graham Binning. I'm the Deputy Chief Fire Officer of Northumberland Fire and Rescue Service. I've been in post by the end of this month for 2 years, and what I'm going to share with you today is a glimpse through the lens that I've been looking through for the 2 years that I've been with Northumberland Fire and Rescue Service. And what I'll also do is share some of the experience and past stories that I bring into Northumberland from the last 15 years, predominantly working in Scotland and also in Hampshire Fire and Rescue previous to that. So, everyone loves a quiz, so we'll start with a quiz to warm everyone up. And it's, don't worry, there's no difficult questions, but there's a bit of audience participation required. I'd just like you to call out, shout out, what services do members of the board naturally associate the Fire and Rescue Service in Northumberland? So what services that we do you associate us with? Fire, brilliant. Top of the class. RTCs, road traffic collisions.
Smoke alarms.
Excellent. Wendy?
Too late, everybody's taken.
Anything else?
Floods.
Floods, yeah.
Planting trees.
Yeah, occasionally when required. No, I think you all go to the top of the class. So, oh, my clicker's not working. Down button. We'll do a Michael Whitty. Next slide. Okay, so top of the class. So this is what I predicted would be what the general public at large would associate the Fire and Rescue Service with. Fires, road traffic collisions, water rescue, storms, cats up trees. The storms bit, you know, from last November onwards into the beginning of this year, I don't need to remind anyone in Northumberland the key role that Northumberland Fire and Rescue Service played in the response to those storms. So they're the obvious things that we are associated with, so I'm actually not going to talk about them particularly at all today. I'm going to spend the next 10 to 15 minutes talking about the things that maybe we're not always associated with, but that's changing and that will continue to change. So it's important to start at the start and the why we do what we do, and that starts ultimately with our statutory duties as a fire and rescue service. I won't read those out to you, but you'll see from the two statutory duties within our Fire and Rescue Service framework document that our role is to identify households and individuals who are at the greatest risk of fire, or those most likely to engage in fire-setting behaviour or arson. And the second part of that, I think, is the key part of what I'm going to talk about today, is our opportunity at any touch point we get to identify wider vulnerabilities and individuals' exposures beyond fire risks. So it's really helpful that our fire and rescue framework has a statutory duty, but we also believe it's absolutely the right thing to do to coordinate our approach with County Council partners. The second two parts of the fire and rescue framework, again from our statutory duty, that I think is extremely important, is that we have a duty to collaborate. We have a duty to continue to review collaboration. And the second part of that, and the reason I smile when I say this, it talks about it doesn't preclude collaboration, although it's lifted from the Police and Crime Act 2017. It's not all about police and crime, and it talks about collaborating with other local partners, such as the local authority, and that's where I find myself smiling, because as a fire and rescue service in Northumberland, we are part of the County Council. We're fiercely proud to be part of the County Council and the opportunities that come from that. And we aim to continue to weave the contribution of our fire and rescue service, your fire and rescue service, into the rich fabric of the County Council offering. The Fire and Rescue Service, as you will all know, it's a world brand. We're unique in the regard that we're held across communities, and we're universally welcome across every door threshold in the communities that we serve. So moving on to the health and wellbeing strategy, the reason that I'm here, the four key themes of that strategy. We contribute to many elements across that through our prevention strategy. And you'll see the focus we have there within that strategy about safe and wellbeing, our well-established Prince's Trust team programme for young people, our schools education programme for children of school age, of all school ages, our Extinguish Fire Awareness programme for children and young people who are demonstrating a fascination with fire, and then finally our well-known and well-loved Fire Cadets programme. But today is really about me talking about our approach to safety and well-being. So the title of the slide, From General Approach to Intelligence-Led. What do I mean by general approach? If we go back to the origins of home fire safety, for a fire and rescue service, that was predicated on us conducting a home fire safety check. This was a general approach to ensuring the highest possible level of provision of smoke detection within the houses of the residents of Northumberland. This was consistent with the national approach, but it was only ever going to work for so long because we would saturate the houses that would have it. It has demonstrated a higher level of protection. But ultimately, it didn't change behaviour. It only alerted when the fires happened. So the fires still happened, but we just got an earlier alarm and alert that those fires were happening. The policies that would have backed the home fire safety check back in the day would have been policies written by fire professionals for fire professionals. And what's different now, as of July of this year, we've launched our safe and wellbeing policy. Going back to the content of the national framework document that I shared with you at the start, we have rightly, fundamentally refocused our efforts on identifying the citizens within Northumberland who are at the highest risk of injury or harm. We couldn't do this on our own, so for the first time ever, Northumberland Fire and Rescue Service have co-produced a policy with that list of partners who you can see bring completely different priorities and the lens that they look through when prioritising their work. We set up a self and wellbeing policy group to devise and co-produce this 2022 policy. And the basis for this co-production, and another thread that weaves its way through the health and wellbeing strategy, is making every contact count. And this, as I said, this has led to a fundamental reframing of the Northumberland Fire and Rescue Service offering to the communities of Northumberland that we serve. So, a whole systems contribution, one of the four tenets of the health and wellbeing strategy. How do we deliver against that? Our new safe and wellbeing policy, an evolution of that home fire safety check, as you would expect, it still has home fire safety as a priority within it. But now we have a wider scope to looking at and training our staff to recognise people at risk of slips, trips and falls, those people in our communities with early signs of onset dementia, and alcohol and smoking. To support that, our teams are trained. We have partner referral processes in place. They are supported with a platform of an all risks questionnaire, which is an all risks person-centred questionnaire, which focuses not only on the lived environment that someone's living in, but the conditions of their health and their state that they're living within their home. So, collaboration. What happens when we don't collaborate? When we fail to identify our most vulnerable people within our communities or collaborate to achieve better outcomes, these situations continue to exist. And this is the point that I talk about, where I bring my previous experience, my previous moments in time from my previous career into Northumberland for now, and also for how we shape our offering in the future. So the people that live in this situation, an old lady living in this environment, she will have had multiple small touch points, probably with multiple organisations, multiple agencies at different times and for different reasons. But the multiple dots didn't join up. And sometimes if the multiple dots don't join up, or they join up too late, unfortunately, sometimes it is too late. And this is what happens. And the old lady who lived in that flat, the dots joined up too late. And then we're back to talking about what we talked about at the start, about what people associate the fire and rescue service with, which is coming to fight the fire, where we would always rather prevent the fire happening in the first place and make people safer in their homes. The wider extent on the back of the tragic loss of this lady was that 42 flats that you see in that flat block were emptied on the day of the fire due to water and smoke. 1 year later, all 42 of those flats were still empty. So you can then imagine the impact on the people that lived in the flats, the local community, the local economy, the local authority, the housing provision that was required, the children that a year later that were still requiring taxis across the towns to maintain their schooling. So what can we do that's different? When we do join the dots, collaborate and share what we know with other agencies or partners who we also know have a contribution to make, the vulnerabilities will still exist. And if I can just go back to the slide there and raise your attention to the date at the bottom of that slide, 14th of July 2011. I said at the start, we sometimes have moments in time. This was a moment in time for me. How do we prevent these things happening again? So the 14th of July 2011, moving through to not even a month later and joining the dots, the people still exist. They still have the multifactorial health issues. They still have the vulnerabilities. This was a man who was living alone, multiple touch points with multiple different agencies, but now we started to join the dots. And what we started to understand was that actually his wife had died, he'd had a series of strokes, and he couldn't wash himself anymore. His mental health was deteriorating and his physical health was deteriorating. But we joined the dots, and when we do, we've got a chance to do things differently. And for the most vulnerable community members, they have a chance of improved outcomes. A walk-in shower to keep himself clean, and an aspiration to be fit and healthy, and also a will to share with me his story. This is old John, and he's asked me back then to share this story with whoever, whenever, this message of collaboration needs to be shared. So my moment in time has led to old John travelling with me for many years now, wherever I've worked. I embrace the opportunities which come from Northumberland Fire and Rescue Service being a full member of the Health and Wellbeing Board. And I ask you to ask yourselves at every forum, at every board, at every community event, committee that you attend, of which they are vast and varied, should Northumberland Fire and Rescue Service be there? And if we're not, why are we not? And can we be? My commitment as a member of the board and also as your Deputy Chief Fire Officer is to shine a light from within Northumberland Fire and Rescue Service to land on all those partners and agencies who can benefit from our contribution, ultimately to give the best outcomes to the people of Northumberland that we serve. So I thank you for the opportunity to be part of the board and present to you today, and I welcome any questions.
Thank you, Mr. President.
Thank you.
In every sentence you just made. Thank you. Are there questions for Mr. Binning?
Just wondering if you like just to say an example of what you've done for our looked after children in terms of the promise from the Fire and Rescue Service, which I think covers the areas that we want in Best Start in Life anyway.
So yeah, we've committed through our corporate parenting commitments to, I think we were the first department of County Council to write a corporate parenting promise, and that is our commitment to the young people looked after children in Northumberland and how we will shape our products at every stage to be considering what where they fit within our priorities.
As part of our new service offer in Northumberland with the 0 to 19 service, we're introducing a home environment assessment tool, which it was started actually to identify the early signs of neglect in 0 to 5-year-olds particularly, but it's kind of extended from that to be much more around that, yes, but also about home safety. And because it can identify through that home environment assessment real key indicators of risk. So I think there's an opportunity here for making every contact count to work together, really looking at that home environment assessment tool. One, if that's a common tool that both our agencies can use, and indeed other agencies as well. But more, when we identify a risk, you know, if we can work together with that risk. So I think there's a real opportunity there, if we could maybe discuss that.
Absolutely, and if we can maybe meet after the meeting, that would be great. I think that the opportunity through making every contact count to be as holistic and have as few contacts as possible, and if you can have a multitude of interventions from one agency at one point, that would always be our preference. One thing I have led previously was a whole systems approach of safety from children and young people, from clips on cupboards to prevent, you know, children and toddlers getting into gel tabs, through temperature gauges for baths, so that young new mothers who are maybe not well versed in pouring a suitable temperature of bath for their young people, but also that temperature gauge to be able to help older people to be able to understand what temperature they're at. So there's a multitude of things. Plug covers a whole lot. So yeah, I'd be really happy to have a conversation off table. Thank you.
Thanks, Chair. Thank you, Graham. And you know how appreciative I am of the collaboration that you've done with communities together and the strength that you've given that team to get involved in the work that they do. And I think it's just important to reference it. This isn't the work that you do at an individual level. The added value that you're giving at the moment at a place-based, with a place-based view, certainly in the Hearst, you know, you've got senior officers in there who are looking at a holistic collaboration around what could be made better for a whole environment. I think that's really powerful, and I'm looking forward to how much more we can do. Thank you.
Thanks very much. And we've also been signposted now for some of our key middle managers to embark on some of the asset-based community development training that Jill's supporting us to set up. So that's that community connector element. So thank you.
Morning. I'm Pam Travers. I'm the Group Director for Mental Health Services at CNTW. And I was just thinking, I wonder if there's a wider connectivity we can do. So I see the NRP are up there on the list, but I just think there's probably something wider we can do, especially with community transformation and centres and crisis services. So it'd be good to meet afterwards if that was okay.
Absolutely. And another reason why I'm delighted to be on the board. Thank you.
Hello, I'm Julie Boyack. I'm the sector rep to the Health and Wellbeing Board. Thank you for your presentation, which was really informative. I just wondered what work you were maybe doing with sensory groups, because they have some of the highest vulnerabilities, those who are deaf and visually impaired. I just wondered if there was an opportunity to collaborate a little bit with the voluntary sector who are working with those groups to see how we could work more closely together.
Yeah, thanks very much for that comment. And absolutely, Vanessa Easton was a big player in the development of the safe and wellbeing policy. We've got a new contact. I think his name's Ian Stevenson. Is that right, Jim? But I had a conversation as recently as last week. I brought in British Sign Language home safety interventions in my previous role before I came into Northumberland. So absolutely, it's on our radar to develop that piece of work. So yeah, because it's from my previous experience, there was an inequality there was an inequity in our service delivery as a fire and rescue service where we didn't have that service available to people with sensory impairment. So absolutely embrace that opportunity too. Thank you.
Mr. Binney? No? Thank you very much once again. Now we move on to the fifth item. Our strategy, health and well-being strategy, is being revised. There are some thematic groups, and I think each group is going to update what they have done, what they plan to do, starting with Jill. Jill, can you please?
Thank you, Chair. So I'm going to be updating on the empowering people and empowered communities thematic element, and Mo, you're in this with me as well, aren't you? Because we have met. So just as a reminder, if you haven't got the strategy to hand, there's 3 key priorities within this thematic area, which is around ensuring that partners, providers, practitioners and the systems that they work in promote and encompass a more than medicines approach. And just in case you're wondering what that means, if you haven't got the strategy in front of you, that is the likes of social prescribers and health trainers, connected locality coordinators and such like. Priority 2 is around providing people and communities with access to networks and activities which will support good health and resilience. And priority 3 is around support people to gain knowledge, skills and confidence they need to be active partners in managing and understanding their own health and health care. So just to have a reflection on that, Mo, Liz Morgan, Emma Richardson and Abby Conway, we all met because we feel that we are the first step towards understanding what's happening around the communities in relation to Northumberland Communities Together and the Strategic Board, the Thriving Together and the 13 thematic networks that sit within that, and the newly emerging Tackling Inequalities Task Force that we're going to be meeting for the first time in December. We've got the VCSE Liaison Group. We've obviously got the Inequalities Plan, and then Graham chairs a Health and Wellbeing Board steering group that sits under that. We've got an ICS level part of work taking place around social prescribing and the offer there, and then obviously the Health Watch is imperative in all of that as well. So we felt that there's a lot already happening, considering the strategy was written pre-COVID. There's a huge amount happened throughout COVID, and what we would like to do as our first step is take the opportunity for the chairs of those said groups to have a conversation about what is it about that we're already doing that meets the objectives within this thematic group. Is there any gaps or is there any duplication? And hopefully if we can have those conversations during November, December time, then we would like to pull together a scoping workshop with all members of those groups just to understand, is there benefit in one of those groups morphing to become an empowered people and communities group, or are we better as a collective where we come together 3-4 times a year and remain as separate entities but with common purpose? So that's our next step, is to have those conversations back in those forums, pull us all together for a workshop, and we would like to report back in the January. But I'll just pause and see, Mo, if you would like to add anything to that.
Thanks, Jill. No, I think it is a sensible thing to try and bring all of those threads together and having that conversation about the next phase of where this is heading. So look forward to having that workshop discussion sooner rather than later, I think.
Threaded throughout this thematic area, so we will be making sure all the 5 principles and 3 questions are part of that scoping workshop. Thank you.
to the next one, or?
Yeah.
Okay. I think we hope to publish it by April next year, isn't it? Or latest, or something like that. That's the target date.
Absolutely. So we're hoping that we'll get the updates from the other thematic group areas now who are present in the audience. I can give a brief update on wider determinants because Rob wasn't able to join us this morning. And then, yeah, it's as a collective, where do we see is possible for us to have that refreshed information coming through?
Okay. Thank you very much, Jill. Thank you. So any questions to Jill on this item? From the No? Thank you. So we move on to the 6th item.
Sorry.
Sorry?
So I think there was other people to report verbally as well?
Yeah,
Yes,
that's right. Yeah,
that's
yeah.
right, absolutely. So
That's what I thought, yeah.
Graham, are you going to be able to update on the Children Best Start in Life theme, please?
Fine, okay, yeah. I'm Graham Writer. I'm the Service Director for Children's Social Care and currently the Joint Interim Director for Children's Services. Unfortunately, my colleague Audrey Kingham can't be here today, but I'll just summarise where we're at. And in the Best Start in Life theme, the three areas within that are the best quality education, that children and young people feel safe and supported in all areas of life, and also that we support children and young people and their families to make positive lifestyle and social choices in terms of that. So obviously the overall work of both in terms of Audrey and I's areas of responsibility fit very nicely into all of this. And one of the pieces of work that we have been undertaking already is looking at the range of governance arrangements that there are around the partnership work around safeguarding, the partnership work around Children and Young People's Strategic Plan, the Healthy Families Partnership Board, all of those things that I think we can try and streamline and bring together to sit under the Best Start in Life work. So there's a whole range of activities going on, some of which I'll just touch on here, which I think will be relevant for those three particular themed areas. So particularly in terms of the best quality education, undertake a wholesale review of the educational provision to ensure that all children enjoy good quality education, continue to invest in the capital programmes to create an environment which promotes learning, obviously work with schools via school improvement to target those children on free school meals who need additional support to realise their potential, ensure that we maximise the use of the pupil premium to meet the educational needs of children and young people who most need it. There's a whole range of work we have already done around making sure that children and young people and their families get the right support at the right time, which is a key principle of this. So we've looked at our front door, first point of contact services and try and continually refine and streamline those. And I do think we've got an effective response, which means that work doesn't escalate unnecessary into statutory work, but actually we look at the range of services that can be offered through communities, through early help, through partnership arrangement at lower levels of intervention, which I think is a strength here, but that we continue to develop. We've also talked here and previously presented a paper around family hubs, which I think is a crucial development, bringing partners together in localities, working and collaborating much more effectively and developing that for 0 to 19 as well, so for older young people as well, not just for the under 5. So I think that is a key part of the strategy. Obviously, the social work operation as well, which we have very significant oversight of practice there, continual improvement there, and some key performance indicators which will fit into this. The oversight I've talked about for the Safeguarding Partnership already. We're developing and integrating both the adults and children's safeguarding partnership. That is work that is being progressed as we speak, but will fit into the overall governance arrangements that I've talked about earlier to make sure we're streamlining and that we're not duplicating unnecessarily there. Other things that we're talking about, obviously a key focus for us around children with special educational needs and disabilities, and we have been Ofsted inspected around that and seen significant improvements in what we offer, but we equally know there's much more that we need to do around that across our partnership. Working with schools to promote the emotional well-being and resilience of children and young people, trailblazers, educational mental health practitioners in schools. We've also developed through our early health offer increased support to schools again as ways of trying to support early intervention. Within social work, one of the things we've got working with health colleagues and through the ICB is we've got a NEWST team, that's the Northumberland Educational and Emotional Wellbeing and Support team, which I think is a really innovative piece of work where they're linked with and working alongside our social work teams and partners, identifying the emotional and wellbeing support needs for the children and young people, the more vulnerable children that we work with to make sure that we're supporting them in the most appropriate way. Range of ways of supporting parents to understand attachment and effective parenting there. So I think there's a whole range of things that we have in place, working across the partnership, that I think we can streamline, bring together and decide how best that fits in with the strategy here.
I mean, very impressive in how we're working here. What I'm thinking, this update today is really useful in terms of giving the board an idea of the breadth of the health and wellbeing strategy and all the different touch points it has on all the different partners. I think at the end of this element of it, it would be really useful just for us to think, is this manner of feedback from these thematic groups what this board wants? Because it's part of our plan that we set out after our development session. So again, we just need to think about when we're hearing these things, is this the information that we need as a board to be confident that these thematic groups are progressing? Okay, and if it's not, we as the chair and the vice chair need to be told these things so that we can go away and think with the executives about how we unplug any issues that are arising. So I'm really pleased that we're starting to hear some of the things in the strategy, because it's making it real and live. It's not just a piece of paper anymore. It's actually a document that we are reassessing, and we're starting to hear some of these streams. And we heard about family hubs, and we're having discussions about family hubs in other areas. We've heard about the fire and rescue service, a really good... So we're starting to feel how things are working here, I think. So just keep the mind focused as we're hearing these, because I think it's starting to give us an idea of where not only we're doing well, but also where as a collective we might see some gaps. Thank you.
Yes, thank you. 4 themes in case, correct? The first one, which Graham addresses, the best start in life, and the second theme will be on empowering communities. Jill, you are going to give an update. Yeah.
So I've done that one, and then the next one's going to be, I think, the whole systems. Rachel, Alistair, I believe you're going to provide a brief update.
Again, just a very brief update, Chair. I mean, I think the whole systems approach is really a continuation of ongoing work, to be perfectly honest. It's not something new, but there's an awful lot where I think particularly the focus on making every contact count, how we can optimise that across the health sector so that we are maximising those. And there's certainly an inequalities lens with that, in that people from deprived communities, there's almost an overt awareness of trying to capture the most of the health interventions that you can do at that single contact, on the basis that you may not necessarily capture that opportunity again in the future, and then looking at specific targeted interventions across various cancer lines and other bits. But I think it's part of an overarching philosophy, and I think we need to be really cognizant of the fact that mental health is really important within this, because we know that if we look at the ongoing theme at actually the pressures of cost of living and things like that, there will be significant pressures on mental health across the sector, and so it's a case of how we work with partners across community voluntary sector and also CNTW within that, and I think primary care is well plugged into that as well. So anything you would want to add, Rachel?
I guess the other part of it is the ICB is a very new organisation. And my role within that is obviously an integrated role across the council already and the ICB, and that, as it starts to settle, is looking at how we can use our current system transformation board, which many people here sit on, in a different way, so that we can start to make some more decisions, and we'll move together with that, how that links in with the statutory requirement of the integrated care board with regard to the partnerships, and that is all kind of taking shape. And actually it might be helpful at the next health and wellbeing board to bring a paper, an update on some of those governance structures, just so that you can see that a little bit clearer, because that should give us the ability then to work better as system partners going forward.
Just an observation. Yeah, I attend the ICS Ask as well, the region-wide Ask, and every meeting they are still saying this is the update, this is how it's not in its final form. So therefore, this team is, doing this strategy for this theme is a big challenge. I completely agree. Are there any other questions? Graham.
One thought on make every contact count, and I guess it's data, but is there a way of us monitoring how good we are at that? So our touch points between organisations and showing that, we're not having multiple touch points with different organisations, and that once we've got a contact with a vulnerable person or whatever our data says we want to do, can we show that actually people don't go in circles and we don't keep doing the wrong things as you've so well described? Is it worth looking at, or do we just accept that we all do it? Or actually, can we look at it? Thanks.
I suppose the corollary of that is actually, as a result of a single contact, you might end up with multiple contacts, because actually, if we're doing this correctly, you see somebody about one thing, and actually you end up with them seeing smoking cessation. They might need a drug and alcohol service. They might need multiple services. So actually, this making every contact count is about actually how we maximise that one contact as a springboard to others. And so I'm not sure it's about it's not about reducing, it's about actually that holistic approach. And so I think it's a really good question, but my concern is actually if we do this really well, we might end up with a myriad of agencies quite appropriately involved, but the ultimate bit is that actually that has a measurable impact on the output of somebody's quality of life, and that's probably a little bit more hard to measure, and that might be more about how we actually measure the overarching reducing inequalities rather than the numeric number of contacts.
Just to add on to that, absolutely agree. And I think there's different ways to measure, isn't there? And I think rather than quantitative, because I think the evidence is strong around MEC, and it's always tricky to measure prevention often as well, isn't it? What have we avoided? And actually, vignettes, case studies are really powerful when it comes to MEC, where a person is able to tell their story of where that conversation started and where it's led to. And I think that's where we can look differently at some of our indicators for the Health and Wellbeing Board. And we want to obviously refresh our indicators more around closing the gap, as Alistair mentioned, but actually part of the inequalities plan is having our residents' voice louder to accompany the data set. So I would advocate strongly for as many robust case studies and vignettes to come forward in relation to MEC.
I agree that it is around case studies and service user feedback. I think there's an opportunity as well that as we develop integrated pathways, meaningful integrated pathways, you can also develop joint scorecards so that actually when we measure performance and activity, we look at that across services and we're reporting on that across services. So I think there are ways that we can explore joint performance scorecards as well, that individual services look at within their contract reports, but obviously work across and we can report back to the Health and Wellbeing Board.
Jill.
So the final theme is around the wider determinants theme, and delighted to say that we have Rob Murphin as our interim exec director as the lead sponsor for that area. Rob's unable to join us this morning, but he's really passionate to be part of the board and to be able to update future meetings. And just to remind members of the board, there's a lot within wider determinants, but the priority focus within the report is around warm homes, it's around jobs, and it's around transport. So again, there's a huge amount taking place around our warm homes work, for example, which the board might be interested in having a specific update going forward. But just to highlight that we are aware that we want to be able to pull this together in a similar way. We're looking at empowering people in communities. Do we need one group, or is this about collective understanding of all of the work that's taken place? And it comes back to Graham's point earlier about this is about us having that oversight and then having the grip and gravitas to ask questions and to understand that. I think, Alistair, it was you that made the point of what's our power, and our power is influence as a board. So the more we know from that wider determinants work, then we can weave into those aspects, including the likes of combined authority work going forward as well. So hopefully Rob will be able to join us in December for a more detailed update.
To Jill on the last wider determinants? No? Thank you. So I think now we can move on to the sixth one. Yes. I think it's going to be co-led by Graham and then followed by Jill.
What we have just discussed segues quite nicely into inequalities, I think, because we have the parallel piece of work, and Graham's already mentioned how your organisation is going to get involved in some of the work around communities and skills development, around asset-based development and that side of thing, and commissioning differently. One of the top-line things that we agreed at the start of the inequalities plan was to have a compact where all partner organisations take away the essence of the inequalities work and just ensure that their organisations have an understanding and are signed up to it. And it's a piece of work that Jill and I would really like to finish off and have a commitment from the organisations. It may actually be a signature on a piece of paper, as simple as that. And it was really just to check to see where people have got to. From a primary care perspective, I can say that we discussed it with our PCN groups, and there is a part of something called the Primary Care Commission Service, which is about asking practices, GP practices, as part of their PCN groupings to commit to a piece of work. And we already saw the Population Health Management report at the last meeting. And that is a piece of work which has been done through the Primary Care Commission Service. And within the criteria for that for the coming year, it was well received that primary care would sign up to the compact. So we've made some progress with primary care, and really it was just to get some feedback from other organisations about where they've got to with that, and whether we could expect perhaps by the December meeting to have that piece of work finished and everybody aligned to that essence. Jill, anything else you wanted to say?
I think it would be really helpful to hear from partners about where it's at. I know, Pam, we've met from a CNTW perspective. Unfortunately, we had to postpone the meeting with Northumbria, but I know there's commitment there. But yeah, just to hear reflections from everyone today about that idea of bringing it forward. And as you say, if it is indeed signing a document, because that makes it official for organisations, as well as walking the walk in the conversations we have on a monthly basis here in the board.
Pam?
Yeah.
Rather than question the feedback, probably Jill would be helpful, wouldn't it? So within CNTW, obviously we're a broader organisation and just here, but I've taken that back and discussed it. It fits perfectly with what we're coming together and bringing together as our annual plan and our plan for 2030. So there's a complete agreement that that's absolutely fine. And I've asked for some conversations with you, Jill, with our lead around that. But we've compared that with our plan and it fits fine. So there'll be no issues at CNTW.
Yes, Jack, please. Alistair. Sorry.
Just again to feedback from a Northumbria perspective, I would like to say we're walking the walk, even if the compact isn't signed by all parties, and that's not because people aren't wanting to sign, it's just a timing thing. But to me, the signature is not what's important. It's a necessary step, but it's walking the walk that is important. And I think collectively people in the room are doing that. And I'm actually amazed at the number of inequalities conversations that are now happening amongst clinicians who 3 or 4 years ago wouldn't have been having the same lens about the service that they're providing, which is fantastic.
Thank you. Can I just ask whose signature we're waiting for?
I don't think I would say that we are waiting for a specific signature, but I would propose that perhaps at our December meeting we have an item on here that formally just agrees that at the Health and Wellbeing Board we have all as organisations taken that away and agreed to the essence of inequalities and that piece of work. Or we could, I'm open to other suggestions about how we do it, but I would really like the Health and Wellbeing Board to have that level of assurance that we have formally agreed it within the board at some point, that we are all as organisations signed up to that way of working. And if organisations have some reservations of any sort, Jill and I would just be more than welcome, you know, we would welcome feedback, because it's an organic thing. You know, it's about moving organisations through that way of thinking.
May I come back? Could we sort of formalise that a little bit more, do you think, and ask if partners are willing to sign at the December meeting, can they do so, please? Unless there are issues, in which case to discuss them with you, because we're very keen as a council to keep the pace on what we're trying to do here, and partners are hugely important in everything we're doing together. So I would really value everyone's signature on this, to be honest, if people are happy to do that.
Just to remind people what the signature would be signing up to, it would be the 5 principles and the 3 questions that are at the top end of the plan around looking at everything through an inequalities lens, listen to the voice of residents and sharing data better, community strengths are considered first, enhancing our services to ensure equity and access to opportunity, and maximising our civic or statutory level responsibilities. So as Alistair says, stuff we're already doing, but let's be proud of that as a collective, I think, is the opportunity that we've got at hand, whether that's December or January for the sake of getting it right. Sorry, leader, December. But I think it's about walking the walk, and then it's that promotion of the fact that we're walking it together is the power. So thank you.
If we made it in December, there could be free mince pies and brandy for members.
Into the whole thing. Yeah, I'm really pleased to say very nice inputs and questions actually, and we are really into walking the walk rather than just talking the talk, and then monitoring how we do, and there's some kind of feedback so that we can correct ourselves in our journey. Thank you. Okay, if that is the case, we will be moving on to item number 7. I think it's being led by Jill again, I think.
Yep, so briefly from me, and then Rachel and Alistair's going to come in as well. So just a very brief verbal update, just to say that ONS survey data as of the 4th of November is tracking COVID cases and showing a decline across England. We're now estimating numbers of 1 in 35 people are testing positive for COVID. At a Northumberland data level, which obviously comes with huge caveats to it, but it is reporting from LFT and PCR testing. We have been showing a downward decline over the last 5 weeks, and we're currently at 46.63 per 100,000 population. Really, the messages remain the same as when Liz did an update last month about it's remaining vigilant is the key message. And obviously the vaccine remains our #1 priority to reducing harm in our communities. And I'll hand over to Rachel in relation to our vaccination status. But also, if people are choosing to go into enclosed spaces with lots of crowds, then obviously masks remain an option. And it is still the hands-face space, because as we enter into our winter with both flu and COVID circulating, and obviously we haven't had the same immunity for flu over the last couple of years, it's just that case of still keeping airflow going in rooms as much as we can, and being mindful if we do feel unwell and we are able to, then to stay at home during those symptomatic few days. So as I say, the messages remain the same, and I'll hand over to Rachel in relation to vaccines. Thank you.
Thanks, Jill. So we've delivered 111,000 doses in our autumn booster programme to date. Our uptake across all eligible cohorts is at 57.3%, which is above the England and the North East North Cumbria average. So we continue to deliver a strong programme. It is really vital we maintain momentum and confidence in this programme, particularly as we move down to the sort of 50 and 64s. People aren't as keen to come forward for their vaccine, but we really must keep promoting it. And you may have noticed a new national campaign on the television adverts to try and increase that. We are continuing to sort of mop up from a point of view of care homes where there's been outbreaks where we've not been able to get in, but actually we're doing continue to do quite a good a strong performance.
I'd agree with what's been said, that the number of hospital cases of COVID in most of the cases in the last few months have been people who've tested positive but haven't been admitted with COVID as the prime reason that they were in hospital have decreased. So whilst about a month ago we were running around about 100 cases, we're now just about 24. So, and that seems to be about the baseline that we'll stay at. I think it's important that we don't just look at COVID in isolation. Influenza we would normally be talking about at this time of year. There was some epidemiological evidence from Australia that we may have been expecting quite a large spike in flus at the moment. That hasn't materialised to date, which is good. So hopefully that will pad out from the rest of the kind of winter period, because the evidence was that it was going to happen early in it happened early in Australia, and we haven't seen that here. So that's got to be good news. There is certainly an anticipation that COVID will continue to plateau off for the next sort of 6 weeks. There is some epidemiological evidence that it might begin to pick up again in January, and we're partly anticipating a spike mid-January, but we just need to wait and see. That's hypothesis rather than absolute certainty, so we'll watch and wait, and it will also depend on strains. But generally speaking, COVID isn't the main operational pressures at the moment.
I've had one or two residents saying to me that they've had their 4th injection. How long will it be before they have to have another one? What's the plan going to be for the future? If you've got a crystal ball, can you look into it and tell me what you think?
Just get it out my bag, yep. Rachel, we haven't had any further updates. I think it's just very much focused on the here and now of getting as many people through that autumn booster as we can, and anyone who's any stage of their journey around vaccines to complete them based on their appropriate conditions. So.
Minor question to medical people. So I had a colleague who had COVID, who was tested COVID positive. First time within a period of a month, and first time there was no symptom at all, but the second time it was very serious. Is the COVID virus mutating or something, or?
Well, so there have been multiple strains of COVID. There are people whose first exposure to COVID 2 years ago was catastrophic, and subsequent exposures have been mild. I know several people who've had a very rough experience recently, and I think there's part of the immunology to do that. Generally speaking, the Omicron variant is milder than previous variants, but when we say milder, that's when we're talking about hospitalisation and ITU. On an individual level, sometimes people are finding that they're feeling much worse, and that's no different. Sometimes people have influenza 1 year and it will absolutely wipe them out for a period of weeks. Another year it will feel a bit milder. So I think it's fair to say that from an individual perspective, you can feel a lot worse having had COVID in the last month than you would have had if you had it previously, and that's your individual immune system. What we do know is, on average, the current strain is not as serious in terms of hospitalisations and very severe medical complications as previous variants were.
Thank you. No, thank you. I think the next item, 8, is we are to receive a presentation from Mr. Peter Rooney. I think he's running late, so I would suggest we finish the 9 and 10 and 11 and hope that he will arrive in time. So this takes us to item number 9, Health and Wellbeing Board, forward plan. Any suggestions for the next meeting? Or the one after? I think next meeting is in December. December, isn't it? Yes. Tobacco Control Crisis Cafe, living with COVID, and so forth. Yes, please, Jill. Yeah.
Liz also emailed Claire, our police colleague, who's also become an official member of the board, and similar to hearing from Graham today in relation to the connectivity around fire and rescue and health and our strategy, then Claire's very happy to also provide a presentation. We just need to check whether that will be for December or January meeting around the interface.
This is for police, you said?
Yes, absolutely.
That's right,
yeah,
not
yeah.
Cumbria Police. Yes, we discussed that. Thank you. Yes, that's correct. Yes. Yes, Alistair.
Just living with COVID is a recurring theme, and I just wonder if at present there are bigger health issues and bigger issues for Health and Wellbeing Board for it to be a standing agenda item if it becomes serious again in the future. But I think there's a danger both from ourselves and our public that they think we're obsessed with COVID, and at the moment we're definitely not.
So shall we take the view on board and consider?
I would support that, especially as a live streamed meeting and things like that. So I think we keep obviously watchful waiting, and we always look at the data. So should we be concerned, then let's bring it back onto the agenda based on where we're at locally.
Yes. Yes, please.
Just a request for a future meeting. We've now concluded the HR consultation on a new service structure and model for the 0 to 19 services in Northumberland. So would like to present that structure and model to the board. We agreed that in the Healthy Families Board just this week that would be put forward. So a date for that would be helpful as well. Thank you.
Thank you. Jeff?
I'm just wondering if we could have a brief report on the success, or otherwise, of the warm hubs that we've been putting in place. It'd be good to have a sort of a feeling as to whether they're working, or whether we can improve them, or we can do something else. And it's no good waiting to the spring. I'd like to know sort of during the middle of it, so if there's something we can improve on.
I'm sure. Mo or Julie?
Yeah, thank you. Yes, thanks, Jeff. I was just going to mention about the, it would be useful to have a paper on the impact of the cost of living crisis and fuel poverty, which is impacting on the majority of our clients in Northumberland, especially for the VCS sector, and also the warm hubs that are being set up, which are just being set up now. So I wondered if maybe Communities Together, who are leading a lot on that area, and maybe Citizens Advice could give us an update on the status.
Mo, do you want to come in on that? Because I know you're coordinating most of that work.
Yeah, more than happy to do an update and a presentation on where things are at the December meeting, if that would be helpful.
Jeff, yeah. Sorry, Glenn, Wendy and Alistair.
Without being disrespectful to GPs present, have we had any kind of update recently on GPs' surgery opening hours, waiting times, and because we keep hearing that there are issues, could we possibly have an update on that potentially? Just so we know, the position here in Northumberland, which is the place that we really obviously care about most.
Certainly. We had an update to the System Transformation Board last month about the strategy for primary care from Pamela Phelps, who's our commissioning lead at the ICB, and that, so we could ask Pamela to come and give a report at some point in the next few months. That would be fine. Yeah, I'm looking to Rachel because that's, yeah, perfect.
Just the point being that that at one stage, I understand recently, possibly because of illness or whatever, there was up to a 24-hour wait to be seen at accident and emergency at Cramlington. And it may have just been a one-off incident, but we were told that this was because patients weren't able to see GPs, and one of the reasons that they went to accident and emergency. Quite happy to wait a few months, but I'd rather have it sooner than that, because if there is an issue in Northumberland, I think we should know about it and see what we might be able to do about it, if possible.
Then, Wendy, can I bring in Alistair and then come to you?
I just wanted to be clear, I don't think there's any evidence that patients have waited 24 hours to be seen. Everybody is prioritised as they arrive. There's a difference between being seen and discharged within a 4-hour window, which is the national target. And absolutely, we have not always met. There are currently it's about 91% of patients who arrive at Cramlington are seen and discharged within 4 hours. That's 91%. But that does not mean that somebody is waiting 24 hours to be seen. And I just want to be clear for board that that has not happened. And somebody may well be longer in accident emergency than we would want, but they are all seen on arrival by a nurse and triage and things like that. I'd hate people to think that they were sat there, nobody looking at them and waiting a day for a clinician to see them. That has not been the case. There has been cases where they've been seen, assessed and not been discharged from the accident emergency unit within that period of time. And I also think there are delays that are longer. So some people are waiting, having been triaged with minor injuries, are waiting longer when there are peak pressures. But again, that's about a clinical triage bit. So it's just what I want to do is reassure the board that things are, from that point of view, safe. From our point of view, we also want to encourage an overcrowded department with people coming with minor injuries that shouldn't be arriving in ED, then crowds it so that those who are sick, we need to be making sure that they are visible to the consultant team at the time.
Well, I'm really welcome that reassurance, but I do think that actually illustrates the need for us to be talking about this ideally in December, because as we are getting into the middle of winter, we need to understand what the real situation is. So thank you for that, and look forward hopefully to having something in December.
It's a bit of a passion of mine for mental health in the county, that we really don't have any out of hours places for anyone to go other than accident and emergency, which is really not suitable for anyone suffering mental health problems. So I do look forward very much, Pam, to hearing about this, and let's get them rolled out. Let's get them all over.
I'd like to reassure the lead, as leader of the local medical committee, which represent GPs, that there's been a generation of a sort of a belief, mainly sort of generated to a certain extent by the national media, that some sort of conspiracy or undercurrents, or that the public isn't being told everything. And I'd like to reassure the board that here in Northumberland we have an incredibly good general practice. As Alistair started to explain, the interplay between access to healthcare in general is an incredibly complex thing, which I totally agree that it's an issue that involves everybody and all the issues we've been talking about, and I certainly, from our point of view, would welcome it to be discussed in open forum. Thank you.
Once.
My hand was up really about a potential agenda item rather than a response. I was just wondering, and it is a health focus, but we have been talking about, there's the Core 20+10 initiative from NHS England, which is looking at 5 medical conditions that are particularly prevalent in the disadvantaged communities that we all serve. And I thought we've already had discussions with Jim, etc., about how we make sure that there is a cross-cutting approach across health towards those. And I just thought if we were looking at future agenda items, that might be something that would be of everybody's interest, because that stems, cardiovascular risk, reducing strokes, all sorts of things. It is a medical health lens, but I think that it crosses lots of other areas, and it might be useful to bring to Health and Wellbeing Board.
Okay, I think, yeah, Jill, yeah.
It would be great if, because there is an emerging children's Core 20 as well, isn't there? So it would be good to see that across the life course, because I think then again it would encompass all partners of the board, so that would be really positive.
So, yeah.
Yeah, just another item for agenda. Rachel and I were having a conversation this morning. We do need to bring the Better Care Fund plan for Health and Wellbeing Board approval. I will have a couple of hoops to jump through on the council side through Exec and Cabinet for awareness, and Rachel might have on the ICB side of things. But December may be doable for that. If not January, we would need to bring that through if that's okay. So we can tighten the date up in probably about a week's time. But we'd be grateful if that could go on the agenda. Thank you.
Okay. Is there any comment on that one, Jill? Is that okay? Yeah.
So could I just clarify in terms of future agenda items? Because I think what we've talked about a little bit is what's called system pressures around ambulance response times, A&E, just general access to healthcare. We could ask for a brief verbal report on system pressures just to reassure the board that things have been looked at and done from an executive perspective in December, if you feel that would be helpful. But the primary care strategy and what's going on in primary care is a different agenda item, really. And I think December would be too soon for that. So would you like somebody to report on system pressures at the next meeting? Yeah.
Yes.
Okay. Thank you.
Thank you. Yes, Jill.
Just to ask board members, we have talked as a group in the forward plan around having development sessions and thematic areas of focus as well that are perhaps slightly longer than an agenda item. So everything that's been suggested, it might be worth thinking through. Is this an agenda item, or would this be maybe closed development session, so where we can have more debate and discussion? So I think that is something for us to consider as we, I suppose, continue to mature as a board.
Yes. I think development sessions will be following the formal meeting, isn't it? Yeah, that's the idea. Yeah. Any other suggestions? Plenty of suggestions we had. Some more will do. Yeah. Okay. Thank you. Thank you very much. Right. Now, urgent business. There's nothing actually, except for an announcement. There is a joint ICS-OSC being held in Gateshead on 21st November, 2:30 p.m. I am planning to attend that one. The agenda item is basically what are the winter planning by NHS, and then inequality, and then of course the recurring theme, just like living with COVID, we have ICS updates, how the ICS is progressing. So that is a recurring agenda item. So these are the three items. So if you have any questions, anything you want me to ask in that scrutiny committee, can you please email Jill, and then I will take it on board. Yeah. Okay. Is that okay, Jill? Yes. Yeah. Thank you, because I just want a collated email so I can go ask them and then reply back here. And then, well, since there is time, I thought I would share, I received an email from Northumbria Health Trust, and they have done a fantastic job of collecting statistical data from ONS, and then preparing a local health index. It's an online tool available online. So I just put NE236QT, that's where I live. You put the postcode, it identifies the area, and then it tells you how that area compares with the national average and Northumberland average. So there are about 56 topics they have covered on that one. That's categorized on healthy lives, healthy people, and healthy places. So if you're interested, I think it's good to educate public on what kind of inequality we are talking about and what kind of inequality exists. To my pleasure, I found that we have lots of green. Green means that area is better than whatever you are comparing against. So you can choose Northumberland or England. So Cramlington Southeast has several greens and a few ambers, which means we coincide with whatever the average you choose, Northumberland average or England average, and there are a few reds as well. So it gives a very good picture of where that particular area is lacking. So, and I think I was talking to Leslie, we will send an email out to all the members so you can play with it as well. So it may not be very exciting for public health officials, but it is definitely exciting from the public perspective. And also it's a good piece of work. So I thought I'll share that one. So the next meeting will be held on Thursday, 1st of December. Yeah, that's right, yes. Thursday, 1st of December, and 10 o'clock. So, except for item agenda 8, we have completed everything.
Chair, does anybody have the contact details for Peter Rooney?
What?
I think Peter Rooney was going to be travelling from North Tyneside, wasn't he? So options would be adjourn for 10 minutes maybe, I don't know, and see if we can contact and find out.
I just noticed here, sorry.
Is that right?
1st December. Date of next meeting. In the agenda it says 1st December and in the future forthcoming items, it says 8th December. So we will confirm it. Sorry for the confusion. It could be first.
It'll be the 8th.
It'll be the 8th. That's right, it's 8th. So the agenda is wrong. Next meeting will be on the 8th of December, 10 a.m. Thank you.
Welcome back, everybody. You'll have noticed that the chair has changed. Paul's had to leave for another appointment further down the patch, so apologies from him. So he's asked me to finish the meeting. And welcome to Peter Rooney from the ICB, who is going to talk to us about the North East and North Cumbria draft integrated care strategy. Welcome, Peter.
Good morning, and thank you for making time and space for me on the agenda. And I think you're quite time compressed now, so I will endeavour to attempt some kind of brevity. But I'm hopeful there'll be a bit of time for conversation at the end. So thank you for the introduction. I'm Peter Rooney, Director of Strategy and Planning across the North East and North Cumbria Integrated Care Board. But I'm here very much in a partnership context. I'm certainly not seeking to only represent the NHS. Just by way of context and introduction, some of these kind of acronyms can be confusing, and I know particularly for local government colleagues it feels like the NHS is always reorganising itself and coming up with new names, but the Integrated Care Partnership is a national legislative requirement to be a statutory committee between integrated care boards representing the NHS and all of the local authorities within the area. We very much have an ambition, though, that should be quite an inclusive forum, not just for the NHS and local government, but bringing in other colleagues and other partners from across sectors. One of the key requirements for integrated care partnerships is to publish by December an integrated care strategy. So again, this is a legislative national requirement. And we've very much thought about the strategy as working at a headline level, setting some key commitments, top-level goals, but still leaving lots of space to recognise and respect the work which is already ongoing locally. And the delivery of the strategy really will always be through local services, local arrangements, working with local communities. The legislation has this kind of interesting phrase that local authorities and integrated care boards must have regard to the strategy once it's published. By which I think it means the strategy should inform how we think about services, how we plan services, how we work with communities, and that there should be some kind of alignment between local work and the overarching strategy for the North East and North Cumbria. And really importantly, it should be based on evidence. And all health and wellbeing boards already have joint strategic needs assessment arrangements. They all kind of look different, by the way. I'm not saying that any of these are better or worse than each other, but they're structured very differently, but provide a very rich kind of evidence of local need. And we've also had fantastic support through a task and finish group from public health colleagues, the Office for Health Improvement and Disparities, and others around understanding population need and opportunity for improvement. With a view to the time, I won't labour this. This just outlines the structure of the current draft. Early on in the process, we tried to define an overarching vision, some goals and enablers. And in these kind of bits of work, you get this challenge that for some colleagues, this kind of statement is just obvious and mother of an apple pie. And for other colleagues, it feels like it's technical, inaccessible language. So there's something about trying to get the language right. But the overarching vision is to have better health and well-being for all our people and communities. And well-being being quite a broad, encompassing word. You can't have good health outcomes without good social participation, economic well-being, flourishing communities, and so on. So well-being is intended to be quite embracing. Longer, healthier life expectancy is just that. We want people to be able to die less young and have longer periods of good health. A bit of debate about excellent health and care services, really recognising the enormous challenge that services are under. Just sustaining service provision and recovering some of the impact, particularly through the pandemic period, feels very challenging. But we would aspire to excellence, right? So that's kind of the use of the excellent word. And fairer outcomes really is about addressing inequalities, which is what most of the strategy is about. I'm quite keen on the word fairer. It's quite a childish word, really. You know, kids know when stuff's not fair, and they tell you. Well, our current distribution of health outcomes is clearly not fair, and we need to be purposeful in addressing it. Then the four enablers along the bottom, just kind of picking out the workforce issue, which for colleagues in every sector is a major challenge, and how we can kind of define and enable good career structures across all sectors, and make the best of the amazing talents that we have across all of our communities. I'll do the case for change a bit first, because it's really quite straightforward. We have some of the worst health outcomes in England, and we have had some of the worst health outcomes in England for as long as there are records. So I think, you know, public health colleagues kind of observed we spend too much time admiring the problem and not enough time being purposeful in addressing it. So that's our key point. You can see some of the references to life expectancy and healthy life expectancy. But the case for change has the potential to be relentlessly miserable, really. So we need to reflect. We have some amazing assets, not least the communities that we all seek to serve. And there's lots of reasons for hope and confidence that we can deliver some of these ambitions. On the key commitments, and there could be a very long debate about whether these target levels are credible, whether they're deliverable, or equally whether we're being sufficiently ambitious. For me, the important thing is, are these the right things to measure, and are they the right kind of commitments to be making? Not necessarily over-focusing on the percentages and stuff. But we very much want to reduce the gap in healthy life expectancy between the North East and North Cumbria and England. The arithmetic doesn't quite work like this, but if we improve by 25% every 7 years, in 28 years' time, we would hit the giddy heights of England average. Personally, I would take that deal right now. But I guess there's a debate to be had about that. And to raise healthy life expectancy to at least 60 in every local authority, Northumberland being one of the local authorities where that's already achieved, actually. Smoking is largely a national standard, but drives so much of the morbidity and mortality burden. And the third one is really about recognising the huge gap in life expectancy along the social gradient. So people in the bottom 10% are on deprivation, on average die 11 years younger than people in the top %. I just don't think that's tolerable, really. I think that's very difficult to defend. And suicide rate, we've had higher suicide rates for at least the last 20 years, but we selected this really as a population health measure around how we're doing around broader emotional well-being, psychological well-being, etc. With a view to the time, I'm not going to go over the kind of key things in healthier, longer, around fairer. Core 20 plus 5, Core 20 is the 20% of people who live in the most deprived areas in the country. The most striking thing for the North East and North Cumbria is, for us, that's actually 33%. A third of our people live in the 20% most deprived. Plus is other groups who have significant disadvantage and 5 key clinical areas. Again, with view to time, to try and have some conversation, I'll skip through the excellent health and care services bit, but just want to point out about parity of esteem between physical health and mental health. It's a key commitment in the strategy, but also an intention of parity between services. So recognising the contribution that everyone makes and that we can only be successful together. The enablers I've kind of already mentioned. Just on the bottom one about the environment, we've included that firstly, it's just the right thing to do. But secondly, environmental factors significantly adversely impact on emotional well-being, mental health, and indeed physical health outcomes. So from a health and well-being perspective, it's important. Lots of engagement work, including what we're doing now. The key thing I think to flag is it is a draft. I will be desperately disappointed if we don't make significant amendments. We'll take any feedback that is constructively intended. So criticisms, endorsements, improvements, amendments, please provide them. There's an online survey that's quite easy to fill in that enables people to do that. And as of this morning, over 200 people have taken that opportunity. Then for delivering the strategy, certainly from an NHS perspective, we've got the joy to look forward to producing a detailed 5-year plan. We would want local areas to continue the fantastic work they're already doing. The kind of primacy of place is still deeply important, but we would encourage all of the areas to kind of reconsider and revisit their own plans in the context of the broader strategy. We're heading towards the next ICP meeting is December the 15th, which is when colleagues will be invited to approve, amend or reject the strategy as we get to then. But as I said, we would very much welcome all feedback. And that is me. Thank you very much.
Thank you, Peter. We've already mentioned Core 20+5 this morning. I think Alistair mentioned that, so that's a nice segue that we can see parallels with what we're already talking about. Does anybody have any comments? Jane?
Sorry about that. My comments are, I would hope that none of the place strategies would be inconsistent with it. However, and that's in terms of the broad overarching aims. However, I did have a little bit of a problem in my brain of translating the quantitative. And I think knowing the background, you've given a little bit of background to how you've chosen the quantitative aims. And my question is that discrete quantitative aims are always a hostage to fortune. And, you know, how are we going to be looking at this? You know, we need to know if we're going to translate this into action across our incredibly complex and I think already very well integrated system, how are we going to do that? And also, you have got obviously the biggest ICS in the country with enormous variation. Are we talking about isolated? And we have, as you say, some of the most deprived and some of the richest and least deprived in the country. How are we going to translate that? And we don't know how that breaks down incrementally between Blythe or rich bits of County Durham or the west coast of Cumbria, you know, in terms of these things. We all know that, for instance, suicide rates vary tremendously between our... and my second, perhaps more controversial question is, to what extent is this strategy going to bind the investment decisions of the ICB? Because you did say you want to preserve everything that's going on at place.
Wow, thank you. I could hear you fine, Jen. Chair, did you want to see if there are other questions, or do you want me to address these? How would you?
Yeah.
Thank you. David Thompson, Healthwatch Northumberland. It's a very, very comprehensive strategy and a not unexpected list of key issues on pages 31 to 38. But I noticed there is no mention of the ambulance service and the response times, which tend to be red rather than amber and green. So I was wondering why an issue of concern across the region had not been specifically identified as a key issue, if I may, please. Thank you.
A couple more, Graham and then Alistair.
Yeah, it's just a comment, Graham Wright, interim Director of Children's Services. It's just, I'm very pleased to see about children in the strategy, but obviously for me the issue is of maintaining children as front and centre of that strategy. It's a comment rather.
Alistair Blair, Medical Director at Northumbria. Again, very good strategy. I suppose my only question, which I think applies in other forums as well, some of these are really admirable, but they're also outside the scope of healthcare. If you think about the changes that are mitigable by healthcare, it's about 10% of some of these. So how do we achieve these without, this needs to bind into local authorities, combined authorities, businessy, industry, all sorts of other bits to actually achieve some of its goals, because it won't be achievable by health alone. And whilst it's great that we are cognizant of these or consider them in decision making, it's also, we ain't going to achieve this as the NHS or healthcare or local. Individually, this is a wider bit if we look at the aspirations which are fantastic within this.
And final comment to Jill and then back to Peter.
Thank you. Jill, Deputy Director of Public Health, here on behalf of Liz Morgan, and I appreciate how much you've been working alongside Public Health to develop the strategy. I think it's just back to those ambitions around closing the gap. And I know you said it's not so much about the percentages that you're interested in, but more the principle of that. I'm just mindful when you said about Northumberland's already achieving healthy life expectancy. Obviously, within Northumberland, we've got a gap from 70 years to 53 years. So I'm just mindful of the comms that comes out around some of this, that it may appear that Northumberland are doing just great and we've got significant inequalities that we need to do a lot about still. I think the second point links with Alistair's point around how much of this is about healthcare in relation to inequalities, and then what's our relationship at place where we will be able to do much more around the wider determinants. Thank you.
Over to you, Peter.
Wow, well, thank you. I'm not going to have to dash straight off, so if anyone wants a follow-up conversation, I'm happy to stay for a little while. Jane, just kind of picking up some of your points. So inevitably when you set targets of this nature that cover a very big geographical area, there's kind of a question, partly links to what Jill said about what does that mean here? And is there a potential of kind of creating some perverse measures really that could theoretically disadvantage a particular place? Well, we're desperately keen not to do that. What we want to see is an improvement on all of these metrics everywhere, but very clearly the biggest improvement where it's most needed. And I think that there's inevitably kind of an association with that about how we deploy resources. You know, there are going to have to be some difficult discussions about if you seriously and credibly want to be purposeful about addressing inequalities, you have to think about resource shifts. But you need to do that in a careful, respectful, considered way that doesn't add further disadvantage somewhere else. So there's definitely a resource kind of connection. And I think in the way you'd understand, a lot of these kind of composite measures, they interrelate with each other. But some of them are meant to be kind of minimum aspirations, a kind of a baseline, including the point about 6-year healthy life expectancy. So we would not want to see that reduce in Northumberland for some kind of artificial way. In terms of the ambulance service, and there are lots of other examples where people are not receiving the service that they should receive right now, across lots of different standards and NHS commitments, and indeed for social care colleagues. We kind of took a decision that, maybe wrongly, to think about longer term population health measures. But we are getting a kind of a challenge about, but how does that help me get an NHS dentist for my child this week? Or how does that make sure that if my grandmother has a fall, that an ambulance is going to come on time? So there's kind of a challenge for us about rebalancing a little bit between these longer term kind of ambitions and some immediate service delivery issues, which are deeply difficult. I guess my reflection would be, having perhaps spent too long in this kind of work, that we want to signal a shift in the accountability. So there have been times, Alistair, you've been there back in old Northumberland days, love to see you by the way, where the weight of accountability is typically about ambulance standards for our waiting times, how many children are waiting for CAMS, those kind of measures. And they're important, but we want to also have an accountability about really shifting the dial on some of these health inequalities. And maybe we've got the balance wrong, so that's kind of the broad answer around the ambulance service. Graham, we've had loads of people have said, there's not enough here about kids, in more professional language than I just did. So it's definitely something we want to redress. If you and other Directors of Children's Services have got some views about how we might do that well, we'd want to be attentive to it. And I think it probably is one of the parts which is underdeveloped in the strategy. So very happy to take feedback around how we could do that. When I mentioned in the slides the call for evidence, the single biggest theme we received was about children's emotional well-being, mental health services. Single biggest factor. And if you think about children who have adverse childhood events, that really sets a lifelong context, including physiologically actually, for some of the healthy outcomes we want to achieve. So that probably is understated, and happy to try and address that. Alistair, on these kind of target levels, you kind of could say, you know what, if someone just solved the deprivation issue, if we were a fairer society, a lot of these things would solve themselves. And you can kind of feel a bit hopeless about that because, you know, in the way you described, health and care services only have a relatively small impact on some of these measures. So I think there's three things. One, how we engage those broader partnerships. Two, how we advocate effectively. But three, there are things that we can do. And, you know, you would know from your own practice about, for example, people from more deprived areas typically present at later stages with cancer and have poorer outcomes. Well, we can do stuff about that. So I think it's been purposeful where we can be, but you're absolutely right. These are broader kind of societal challenges. And Jill, I think just kind of coming back to, but what does this mean for us here? And even at place level, kind of what this strategy might mean for some communities in Alnwick or Hexham may well be very different to what it might mean in Ashington, Blythe, Morpeth. Because you've actually got a very diverse patch. I think the only thing I'd kind of point back to is we want better everywhere, but most focus where it's most needed, including those places within Northumberland where it's most needed. And if helpful, we can try and produce some kind of indication as to what this might mean for each local authority area and kind of connect that up a little bit with your health and wellbeing plans in your JSNA. So it'd be great to have a conversation about that. Apologies, I know we're past 12.
Okay, right. Alistair, I know are you all right for a minute? Or do you need to go? I knew you were on a time frame. Okay. When you need to go, just go. Thank you. Thank you very much, Peter. What I'm thinking is you've heard feedback from the group today, but actually I think probably we just need to absorb this a little bit, and if you would like us to put something together in a formal response to the strategy, so there's a health and wellbeing board, we have actually responded. I think we should. So probably comments back to, do you want them to come to you, Jill, or myself? And I don't want to give you work. I've already got one job. Okay, and I think we will, but for me it's really about what does this do to enable us with our thematic plans about what's going on. So within your theme areas, if you think there is something that, as Graham has stated here, you know, let's just do it from that perspective and make sure we align as best we can, but influence if we think it's not going to enable us to do what we believe is right for Northumberland. Okay, so I will formally close the meeting, I think, if that's all right with everybody. Thank you very much. We have overrun a little bit today, so thanks for staying.